will thank you all for coming, especially our guest speakers, and I'm only sorry that I can't spend more time with you personally. I'm going to say my thanks now to Charlotta and Andrea, who've worked very hard for this session, and I hope you all have a great and enriching time. And the point really is to come out with new thinking, new research, new insights into this very important area. I'm, as Charlotta said, an academic GP, and many years ago I was in a small minority of doctors in training who did a social science intercalated degree. And for a long time I didn't really realise that I'd used that knowledge. It was like a wonderful year out where you did proper universities, things like essays, and went to the library, and then plunged back into clinical training, which in those days was, I think, very outmoded, but that's another story, that's not what I'm talking about today. Please come in and find a seat, don't worry about crossing, it's fine. When I started in general practice, I realised very, very quickly that the lives of my patients was entirely influenced by who they were, where they grew up, the culture they were in, the living they could make, or indeed not. In fact, what we'd call these days the social determinants of health. And it was very much our practice's wish and aim that we would work with the community to try and get a bit upstream of the point where they needed a diagnosis from us. And then as I went into academic, I guess that I used more the sociological constructs around power and culture and its economic basis to try and inform the way I think about education and what we're trying to achieve. But we're talking today about the question of diagnosis, and I just want to say a few words about the context of diagnosis and the role of expert generalists. So, as a GP, I am aware that when somebody comes to the surgery or makes an appointment by email or over the phone, whatever, they are bringing to the encounter they now wish to have their whole background, who they are, their culture, their understanding of how the body works, how the mind works, and how the two interact. And if they don't have, everybody has a different version of that, so that is partly about education, it's partly about insight, it's probably partly about physically who we are. Some people seem to be much more sensitive to the signals that their body sends them than other people. And so there's a whole complex, unique combination of factors that people bring to the question of symptoms and the diagnosis. And beyond that, they will have their own history of the use of the health service. Has it served them and their families and friends well in the past? Do they have conditional trust in it, or do they have conditional mistrust in it based on their previous encounters? In some systems, they will be worried about money and insurance and whether they can get a service because, they're going to have to calculate, do I go now because it's going to cost X, or do I go later because it might cost Y? And all sorts of complex things are brought into this encounter as well as their norms and insights. So one of the things we've drawn on in sociology for teaching students is when people come, why have they come now? And my first academic boss, David Hannay, wrote a very good book based on his research in Glasgow called The Symptom Iceberg, where you look at most people have symptoms most of the time. Most of us live with symptoms most of the time. We may or may not be worrying about them, but we're not thinking, wow, this is weird, maybe I need to know what is going on. And so something tips people through that first threshold of the iceberg. Sometimes it's not just pain or uncertainty or something new. Sometimes it's another person, often family or friends, or something you see in the media pushes people through the threshold to coming to the encounter where they think they might have something new wrong and they want a diagnosis. So all that stuff about social media, especially in this day and age, I think is another rich ground for research around the sociology of diagnosis. But for me and my discipline, the heart of this is the consultation. So now let me take you through. This person with all that background has managed to make an appointment, and I am calling them in. So my first bit of diagnosis, again, may be influenced by, do I already know them? Am I bringing anything to this encounter? Yes, I am. I'm bringing my whole training, my whole assumption about what the diagnosis is about, my whole learning, my expertise, but also my relationship, or indeed not, with that person. And I will also use the electronic record. So even if I don't know them, or whether I do or not, I will have a look to see what the headlines are. When did they last come? Have they already seen somebody else? You know, what is their background? Do they have any conditions that might be relevant? So in my head, I am positioning myself to help make anything of this encounter that is coming towards me, and then I go and call them in by name. And I watch them as they come in. I see whether they were sitting alone in the corner of the waiting room, whether they've got kids, whether they look harassed, whether they look relaxed, what were they reading? And all that starts to inform the encounter. Let's assume this person who has now come in needs a new diagnosis. Again, that's our focus. They're not just coming for a drug check or whatever. We're on diagnosis here. So then how we talk, what they say, how they express themselves, the words they use, what is worrying them needs to come out. So in our teaching around the consultation, and again Charlotte is a great lead for us in this regard, we are trying to get students, young doctors, to consult in a way that will help them to help the patient. And in the purpose of diagnosis, now not only means helping the person to tell you everything, so that you have a full picture of what is bugging them and what has been going on and what actually the detail of that story and its background is. But it's also about how you then drill down into that, how you ask the medical questions, whether you can make those questions make sense to this person. And that will differ according to the way they use English or not, the way they already have insight into what might be going on, what health beliefs they've got, what their concerns are, what their expectations are. So all that comes into best practice in making diagnoses. And behind that, the doctors have to have the core knowledge. Now you might say, is the core clinical knowledge, the scientific knowledge, is it really where we're at? Not enough, but it has to be sufficient, because actually the public want nice doctors who listen and understand and seem to take their views on board, but they want good doctors who get the diagnosis right, who start them on the right path to sort the problem out. So we, doctors, also have to know what we're doing, ask the right questions, examine people properly, order the right tests, and get a diagnostic hypothesis. And the job of GPs, or sometimes other frontline generalists in other settings, is to start the diagnostic hypothesis. That is very different than the stage somebody is at by the time they are in a hospital setting, where the patient's had a load of tests. The pre-diagnostic chances are very different than the post-test chances of a diagnosis. So there's a whole literature around epidemiology and how you make diagnosis that I think it's also very relevant here. Let me then take you on. At the end of my consultation, not only have I got to have some diagnostic hypotheses for this person, but I also need to understand them. And a lot of this is about sense-making, the literature, about the narrative, the story. What we want is to start to make sense of our experiences. People don't mind if I say, I'm not sure what is going on, but they do want to understand where I've got to in my thinking, and to share that, and to make sense of it together. So the literature on shared decision-making with a diagnosis, it may simply be, yes, I understand why you want me to have these blood tests and an X-ray, doctor, and I understand what is going to happen after that, e.g. I'm going to come back and get the results, and then we'll see where we've got to. And even if they are left with some uncertainty, my experience is most people can handle that, And the ones who can't are another interesting research group who will have their own history and the whole story about multiple somatic symptoms, unexplained symptoms, chronic fatigue, and loads of really difficult questions for some patients who have chronic symptoms that are not labellable. Is a real interest of mine, and I think it's really important that we keep working with that community around diagnostic issues. Anyway, so now we've got down to people going out of the room. I've done this little bit for now, and the only question then about the next bit of diagnosis is who is holding that patient? Where are they in the system? Because we know that until people have a reasonable degree of certainty and can go off and self-care and manage and agree to take the drugs if they have got a diagnosis and these drugs might help them, this episode is unresolved. And so another bit of this is about continuity and how important that is for diagnosis, because diagnosis, certainly in community settings, takes time. Natural history tells us sometimes what is going on. Sometimes we just have to sit with our symptoms and see if our predictions are right. You know, I think your child's extremely bad cough and fever and horrible sleeplessness and being off their food is probably a virus that's affecting their voice box, the breathing tubes, poor little thing. Nothing I can give except keep taking the calpol and the inhaling stuff. And if it gets worse, call again, and by worse I mean X, Y, and Z. That's a typical encounter for me with a small child. I've made the diagnosis. The mother wants to know what to watch out for. The father wants to know when it might be better and when to come back. And in, hopefully, 90% of those patients, what I have predicted will happen, and that's the end of that. So the diagnosis paid off because I predicted it. But anyway, they are held in the system. They can come back in our system here. Now, let me just go momentarily on to context. Because after we have done a good consultation with best practice and done all our, continuity stuff, there is still the system. And so you're talking also about resources and the economics of diagnosis. And it is, I think, quite clear that resource use is something that diagnosticians in this day and age must be very careful about. So if I send people immediately to a consultant because this patient has abdominal pain that I can't immediately explain, even though I have made an assessment and I don't think it's serious, that will cost the NHS more money than if I hold them for a period and do some of that work with them myself until it is clear that things are not resolving and they do need to go. In other systems, as I said earlier, clinicians, whether in primary or secondary care, are often incentivised for the tests they do. And so the question of how your actions as a consequence of diagnosis influence resource uptake is very much, I think, influenced by the system that you're working in. We have colleagues here from other parts of the world, they may talk about that. And similarly, whether people don't go and don't get a diagnosis and don't get help, as I've said, is often a barrier of healthcare systems, and I hope that our country will hang on to comprehensive coverage free at the point of use, because I'm quite sure that the literature shows that this is economically effective as well as clinically effective, but the jury is currently out. So, costs, absolute numbers of episodes and contacts. Final word I'd like to say is something about workforce. There's a lot of discussion about how best to use who in the system, the patient's own self-care, healthcare assistants, physician assistants, nurses, doctors, direct-to-consultant referrals or whatever, patients who can walk and bypass the stage that I'm tending to work with them at. So I'm hoping that some of your discussion about the sociology of diagnosis will actually look at who is doing what around the diagnosis, because again, that is something that healthcare systems need some recommendations about. There is a huge tendency, especially in global environments where there are relatively few doctors to do this skillful diagnostic work, to push diagnosis down the chain. And the problem with that is that unless you are an expert generalist at your level, where you can take the scope of the patient's symptoms and their background and their views into account when you're making the diagnosis, you may actually have great difficulty doing that diagnostic function. And so I think in systems where we are training colleagues to help us and putting people into different situations, we need to think quite hard, is it best to use their skills for diagnosis or for management and patient education? In other words, to keep the clinicians doing the signposting and the initial assessments, and then to let other colleagues do the management and build-up, or whether, if you are going to put non-doctors into the frame of diagnostic work, what training do they need? What skill up do they need? I've just been in South Africa, they're talking about upskilling a lot of health practitioners to try and improve the service they can offer the public. And a big question is, how much can we upskill people to do diagnostic work? And particularly to avoid fragmentation, because the other thing that happens is, well, I can do a protocol that might diagnose AIDS, I can do a protocol that might diagnose TB, I can do a protocol that might diagnose malaria. But if I've got a patient in front of me who's got a fever, can I do all three? So there's huge questions around training, education and the workforce in the sociology of diagnosis. I hope that gives you some sense of the context that we're having this debate in, from the clinical side and the health system side. Not too big a challenge, is it? Have a good day.